Hello, I'm Dr. Scott Lederhouse. I'll be speaking about craniotomy for brain tumor, which will involve a little bit of an introduction. What are brain tumors, how do they develop, what types of brain tumors there are, and what one would expect as far as imaging studies, MRI scans, CAT scans, etc., the sort of symptoms that one may have, what sort of treatment options there are, recovery time, etc. So this will be an informative video, but it'll also be a video where we'll go over a consent form which should have been provided, and we will review that as well. Now, there are a variety of brain tumors, and some of these tumors may be what we call benign tumors, which means that they can be removed and oftentimes cured. Other types of tumors are called malignant, which means that surgery can be done to treat them. However, they cannot be cured with surgery and cannot be cured with radiation therapy, chemotherapy, etc. So malignant tumors are sort of tumors that will continue to recur despite treatment, and these will be discussed in some detail shortly. As far as what might be the symptoms of a brain tumor, it could be just a type of a chronic headache. Sometimes patients will present with seizures, may present with loss of consciousness, may present with what we call focal neurologic deficits, which might mean weakness in an arm or a leg, or trouble thinking, or nausea or vomiting. Those types of symptoms can occur. Now, there are a variety of different types of brain tumors. The benign brain tumors may consist of what we call meningiomas. These are tumors that occur from the membranes of the lining around the brain. They're a very common tumor. Sometimes they're multiple, but more often than not, they're single lesions. They generally don't produce much swelling around the tumor and can, in most cases, be entirely removed. However, there are exceptions of tumor locations of meningiomas where a complete removal may not be possible, such as if the tumor were to invade certain bone structures or wrap itself around blood vessels and that type of thing, then a meningioma may not be entirely be able to be removed. Even in cases where the tumors, such as meningiomas, are removed, they can recur due to some microscopic regrowth of tumors that can occur over time, and therefore we will generally recommend that patients with meningiomas be followed up periodically with scans to ensure that there's no regrowth, and then if there is regrowth, that can be monitored and perhaps an operation done in the future. Other types of benign brain tumors may be tumors that occur along some of the nerves within the brain. One of the most common would be called an acoustic neuroma, which is a benign nerve sheath tumor that occurs. This is not a tumor within the brain, but it's within the skull. The other types of tumor categories would be in a consideration of a malignant type of tumor. Now, there are malignant tumors that start within the brain, and they're called malignant primary brain tumors, meaning they haven't come from elsewhere in the body. Most common malignant primary brain tumor would be an astrocytoma, and these astrocytomas can be a fairly benign tumor and what we would call a grade 1 tumor, or they can be a very aggressive tumor where it would be called a grade 4, or perhaps the end stage of that would be called a glioblastoma multiforme. There are other types of tumors that occur within the brain primarily, which are less common, such as an oligodendroglioma, ependymoma, and some of the other types of tumors. These are much rarer, however, they still fall within the malignant primary brain tumor category. Metastatic tumors to the brain infer that the tumor started elsewhere in the body, such as a lung cancer or breast cancer, or perhaps a malignant skin tumor called a melanoma. And these tumors can travel via the bloodstream and other routes to lodge themselves within the brain, and thus we call those metastatic brain tumors. Metastatic brain tumors may at times be multiple in location within the brain, called multiple metastatic brain tumors, or at times may be single metastatic brain tumors. Often, if a tumor that has metastasized to the brain hasn't been diagnosed, then we will make attempts to at least diagnose that it's the same type of tumor, because sometimes it might be a separate tumor. And so an operation is often done just to verify that this may be a metastatic tumor that came from elsewhere, or whether it was a secondary malignant primary brain tumor that actually started within the brain, even though somebody may have other types of cancer present. So these are the variety of types of cancers that can occur. Certainly this is a short list of those types of tumors. This is just to give you an introduction on what we call metastatic or primary brain tumors. Now, the location of tumors may determine what the symptoms may be. A tumor in the frontal lobe or in the forebrain may not give much in the way of symptoms as far as weakness. However, they may produce headache, nausea, and vomiting. However, a small tumor that's in an area that controls movement or primary sensation of the body may give significant symptoms, even though there may be a small tumor present. Other areas of the brain may produce with trouble speaking or vision problems. So these can all be symptoms that may come about that would lead one to get a diagnostic study, such as a CAT scan and or an MRI scan. Now, as far as location and tumor removal, most tumors can be removed. There would be a few exceptions to that rule, which would be tumors deep within the brain that the morbidity and mortality of removing a tumor may be so high that removing such a tumor may not be possible. If that's the case, we're still able to do what we call stereotactic needle biopsy, which is a procedure where we do CAT scans or MRI scans, and using image-guided software from computers, we're able to determine the exact location of a tumor and under direct vision be able to actually put a needle within a very small lesion within the brain to obtain some tissue for verification of diagnosis, etc. So that can be done generally very safely with very few risks of side effects from just doing a needle biopsy. However, as far as removing a deep-seated tumor within the center of the brain, that may not be possible. However, most of the tumors will occur towards the surface of the brain, and most of these tumors can be what we call gross total resection of the tumor, which means everything that appears to be tumorous can be removed at the time of the initial operation. As far as the tumors being resectable, as I mentioned, some of these tumors may not be curable, and in the tumors that are metastatic or primary malignant brain tumors, we can do what's called a gross total resection of the tumor. However, we understand that with the pathology and nature of these tumors, they cannot be cured with surgery, and thus we will often do follow-up studies to see what the regrowth pattern is. Additional supplemental treatments such as radiation therapy is oftentimes done. Chemotherapy has a limited role in treating malignant brain tumors. However, there are some protocols for this, but the mainstay treatment is surgery and radiation therapy. As far as resecting even the benign tumors, they will be followed periodically with scans just to ensure that they do not recur, as they can recur over time as well. This is a side view model of the brain. We have the location of the frontal lobes, which would be here. This pink area is what we call the primary motor area, which controls movement to the opposite side of the body. And then the green area is what we call the primary sensory area, which has to do with sensation of the opposite side of the body. So we have frontal lobe, and then parietal lobe. Temporal lobe is down here. In the back of the brain, these are the occipital lobes, with the purple areas being the primary visual cortex for vision. And then down below here are the cerebellum, and then this thing coming down is called the brainstem. So, and then of course it's the same on the opposite side. And these red areas are normal areas of blood vessels that supply the brain. Some of the areas here marked in yellow have to do with speech areas, and so we're very apparent and aware of different areas of the brain that have certain specific function that we want to avoid. This is looking at the inside of the brain after having been taken apart. So this is the very midline portion of the brain. You have again blood vessels that supply the brain. The structure in here is a membrane that connects the two halves of the brain together. This is the part of the brain stem. Back in here is the cerebellum, and this would be the pituitary gland sitting down here. This is an MRI scan demonstrating a side view image of a benign tumor called a meningioma. The tumor is the white area, as can be seen in the upper part of the image. This is a very well circumscribed tumor and was grossly totally resected. This is another meningioma, but it is growing through part of the bone and into the black areas, which are the frontal sinuses, which makes this more of an aggressive tumor. Therefore, doing complete removals of this tumor can only grossly be done, and there will still be residual tumor behind. This is the same tumor as before, however, it had been removed, and this is the recurrent tumor that occurred approximately a couple of years later. This is after resecting that tumor in the same patient previously seen. And as well, the tumor recurred again, and due to this, the patient ultimately required radiation therapy. This is another small benign brain tumor, as can be seen in the white area. This small white area is a small benign tumor in the back of the head, which is actually not within the brain itself. This small area on the left side of the brain is a acoustic neuroma, which is a benign tumor associated with cranial nerves. This series of MRI scans on the same patient demonstrates multiple intracranial and intracerebral lesions consistent with metastatic tumors that have come from some distant place. This is a tumor within the lung, which a primary tumor consistent with a carcinoma of lung etiology. This is a photograph of the anterior aspect of someone's neck demonstrating a thyroid tumor, which turned out to be thyroid cancer. And this MRI scan demonstrates a cystic lesion, which is the dark area containing fluid, with the active lesion being the white area around it. This is consistent with a metastatic tumor again. Another metastatic cystic tumor of the brain. On the right side of the picture is a primary glioma. This is a high-grade glioma consistent with glioblastoma multiforme. This is an MRI scan demonstrating two intracranial lesions on the left side of the picture. This was from a metastatic melanoma, which is a cancer of the skin. This patient ultimately passed on due to multiple metastatic melanoma tumors. The same patient had one of the tumors removed, and another one can be seen on the other side. And this patient had a large sarcoma that had been removed about 15 years earlier, with a recurrence of the tumor over time. This is a tumor after it had been removed, and the patient has done very well postoperatively. And this is the postoperative MRI scan on that patient demonstrating removal of the tumor. In this patient, the white area in the center of the brain is a deep-seated tumor that cannot be removed, and therefore this patient was to undergo a needle biopsy of this tumor. Utilizing computers, we're able to do stereotactic removal and or biopsy of deep-seated or small tumors. In this model, we're able to remove a small tumor that would be difficult to find otherwise. As a result, small brain tumors can be approached surgically to remove or occasionally to biopsy, depending on their location and size. This is an example of a craniotomy hole that we might perform. In this particular case, there may be an incision in front of the ear over the forehead. We have little drills where we do little access holes in the skull, and then a separate drill which will lips out a piece of bone that then comes out as one piece. Once the removal of the tumor has been performed, then the piece of bone is laid back in position with some small titanium plates and screws that hold the bone in place, and then after that, then the skin is sewn back up in layers and the stitches to remove after usually a week or so. This is the routine shaving and area where we would perform an incision for a craniotomy for a tumor. This is what we would call the left frontal temporal area. This is after we've done the operation and replaced the bone flap with use of titanium plates to fix the bone into position. This is the typical skin closure in such an operation. Procedure for surgery, you may have received a written document which would be something like this, and at least this one here says surgical risk, complications, and indications for craniotomy for tumor, informed consent. So we'll go through this document, and you can read along if you have a copy of this. First section is skin. It says scar tissue formation with keloid. That just depends on how your skin heals. Ordinarily, we will put suture that is removed usually a week or so post-op. There can be some healing of the skin that can form as a keloid, which means a scar, and some patients scar more than others. Some patients don't hardly scar at all, and if the incision is behind the hairline, then whether it scars or not, more than likely you won't see any scar. But in either occasion, there is some scar after doing a skin incision. Poor hair regrowth. On a rare occasion, along the edges of where the incision is made, there may be less growth of hair. That occurs in some patients, not all, and if it occurs, the hair growth will generally start to improve over a period of time. However, there may be some immediate retardation of the growth of the hair for a period of time. Numbness around the incision site is occasionally noticed, and if that's noticed, then over time, once the nerves start to regenerate that supply the scalp, then the sensation would return, but that may take several months. Next section is bone. It says bone flap infection with possible removal of the bone flap with plastic cranioplasty at a later date. What that means is that if after doing an operation such as this, if the wound were to become infected, and this would of course be at higher risk in patients that were on immunosuppressive medications such as long-term steroids, or if they have diabetes and have a lot of medical issues, then if an infection were to occur in the skin, and the infection can then go through to the underlying bone. If a piece of bone has been ellipsed out in order to do the operation, then that piece of bone acts as a foreign body. Once an infection occurs in the piece of bone, then the bone has to be removed. Usually the bone is left out for a few months or so until the infection has completely cleared. And then as a secondary procedure later on, then a plastic plate can be inserted that will fill the defect and give a normal contour and appearance of the skull. This is a rare event, but it occurs occasionally and often enough that it needs to be mentioned. Still under bone says cerebrospinal fluid leak with possible need for additional surgery. On a rare case, the membrane that contains the spinal fluid, the outer membrane is called the dura. If the dura is closed and if by chance there's a small amount of leakage of spinal fluid through the dural opening, then this can present with some fluid underneath the scalp. Now if that occurs and the diagnosis of a spinal fluid leak is made, then on occasion the skin and bone would have to be removed again and some additional work done to secure any leakage of any spinal fluid. This occurs in probably less than 1 or 2% of the cases, and so it's a rare event. Next section is brain. It says injury to the brain surrounding the tumor, which may be permanent, temporary, complete, or incomplete injury. Now when we do tumor surgery, we generally try to work within the tumor itself and then slowly peel down the edges of the tumor so that we're not disrupting the normal brain function, but even under the most meticulous care, there can still be some additional swelling that can occur around a tumor after the tumor has been removed. This can cause some temporary neurologic dysfunction such as weakness or in rare cases near paralysis. If it's all due to the effects of the swelling, then over time then this weakness would subside and resolve. However, it may take on the order of sometimes several weeks or more. Occasionally you'll have some weakness that'll clear fairly quickly, so any post-operative weakness or symptoms such as that doesn't necessarily mean that it's permanent, but it may be a reflection of having some swelling after the tumor has been removed. Going on under the section of brain, it says this could result in death, coma, or persistent vegetative state, hemiplegia, hemisensory loss, aphasia, dysphagia. These all mean trouble, inability speaking, understanding speech, hearing or understanding spoken language, or inability to read. All of these complications are exceedingly rare and can be discussed directly with your doctor regarding any specific risks that you may have in this regard. Also, seizure disorder, loss of vision, inability to form new memories. These are all, again, potential risk, and again, discuss this with your physician. Inability to cure the tumor with need for chemotherapy and/or radiation therapy, or possibly additional surgery at a later date. And this would apply to virtually All of the malignant tumors and even the benign tumors, you still have to follow up with possible surgery in the future depending on any kind of recurrence of the tumor. Possible excessive bleeding from tumor removal requiring a blood transfusion. This is a rare event. Some tumors are quite vascular, which means that they have a lot of blood flowing through them, and as a result they can lose enough blood that requires a transfusion, but the transfusion rate for taking tumors out is probably less than about 5% of the cases would need a transfusion, so the likelihood of needing a transfusion is very, very small. Injury to blood vessels resulting in strokes. So we are operating within the brain. These tumors are removed and we make every effort not to disturb or violate any of the normal blood vessels that supply normal brain tissue. However, in the event of taking out a tumor, if a blood vessel occludes, then this could result in a stroke that could produce some neurologic deficits that could potentially be permanent. But again, this is a low risk of this. Prognosis, it says eventual death due to malignant brain tumor, whether primary brain tumors or metastatic. So as I mentioned, the treatment that we give is palliative, which means we're not going to cure it. We do what we can in treating the tumor aggressively by shrinking it down with surgery and radiation. Beyond that point, at some point in time, there will be eventual death due to malignant brain tumors, and again, this is something that you can discuss with the, your individual physician regarding prognosis, etc., depending on the type of tumor that may be present. And it says prognosis depends on tumor type, size, location, and accessibility. As I mentioned, some tumors can be entirely removed, others can only be partially removed, and in the variety of brain tumors that we've discussed. Possible recurrence of tumor even if a benign tumor, as we've mentioned. Next section is general risk. It says death due to the surgery or anesthetic. I don't think we've ever lost anybody, but that would be an exceedingly rare event. Allergic reaction to medications, a risk of AIDS and hepatitis from a blood transfusion. So as I mentioned, the likelihood of getting a blood transfusion is very small. Prolonged hospitalization for some complications of a tumor resection, possible long rehabilitation. So this would apply to someone who may have a post-op neurologic deficit such as weakness that may require an inpatient physical therapy, etc., in order to get back and being independent. The above risk and potential complications are not meant to be a complete list of all potential problems that can arise, and therefore may not be limited to what has been listed in this outline, such as a urine infection or pneumonia or some unrelated event that occurs from just having tubes, etc., and from being in the hospital setting. Certain risks must be considered with any surgery, although every precaution was taken to avoid complications, absolute guarantees cannot be made. Clinical experience and judgment indicate that in general surgical risks are limited. However, surgery remains a human effort. Unforeseen circumstances can complicate any surgical procedure and lead to serious or even life-threatening situations. Although such complications are infrequent, you and your family should feel free to discuss the question of risk with the physicians. For any uncertainties patients may have, we encourage second opinions from other qualified neurosurgeons. I've discussed the above pertaining to craniotomy for tumor surgery with my physician. He has explained the procedure and risk and complications to me in non-medical terms so that I understand them. He has explained my non-surgical options as well. I've been provided a copy of this form for my later review. And then it would have my diagnosis is, and it would be specific as far as the location and suspected tumor type. And then I give my consent for a physician to perform the following operation, which would again be a specific operation, right versus left, frontal, temporal, etc. And then place down there for you to sign the document and a witness, which is ordinarily a family member, and date that. Once we go through this and make the arrangements, then we would get the approval of admission through your insurance, unless you're already admitted to the hospital, and go from there as far as setting up a date. You may be put on these steroids called Decadron before the operation, possibly some anticonvulsants as well, which would be left up to your physician regarding your particular case. Now, while in the hospital, the patients are generally in the intensive care unit right after the operation. If the tumor has been removed and the tumor is not so big and the patient is awake and alert, then right at the end of the operation, the breathing tube from the respirator has been removed and the patients are transferred up to the intensive care unit while they're watched closely by nursing staff for blood pressure elevations, that type of thing. While in the hospital in the intensive care unit, as well, neurologic evaluation is evaluated every hour or so just to make sure patients are awake and alert. And then as a typical routine, we'll obtain a CAT scan the day following the surgery just to make sure that there's no problems such as a postoperative bleed or additional swelling or any other untold event that may have taken place that we may not be aware of. And this is done as a routine after craniotomies for tumor. The rest of the hospital stay, if a patient is doing well, generally is transferred to the regular medical floor after the 1 day in the intensive care unit, where they're then ambulated, and as long as patients are eating well and their vital signs remain stable and the wound looks good, and at whatever point they're off any shots for pain and able to eat and ambulate, then they can go home. This sort of surgery is not particularly painful. The only thing that feels really is the skin. The bone and the brain don't feel, and so it's not a particularly painful procedure to undergo. In areas where there's an incision in the frontal area, such as just behind the hairline, or where the skin might be opened up, we will frequently see swelling that may occur over one eye or the other. This swelling is very common. Sometimes the swelling gets enough that the eyes will remain shut for a few days, but after a few days then the swelling goes down and the eyes can be opened up. So don't worry about any swelling around the eyes. That's a natural reaction of just doing the operation. This can vary from patient to patient. Some of the brain tumors can be removed and the patient may go home in a day or so. If there is a larger tumor, or if there's any postoperative neurologic deficits such as weakness, that type of thing, then patients may be hospitalized longer and may actually require postoperative physical therapy, etc., until they're able to go home. Generally speaking, though, the hospital stay would be a few days after removing a brain tumor, and then follow-up would be in the office to check the wound and check the progress and make any further recommendations regarding any additional treatment. As far as wound evaluation, then we take the stitches out usually about day 10 or so from the time of the operation. And if any supplemental treatment such as radiation were needed, then radiation realistically can't start for a couple of weeks post-op anyhow until the wound has had a chance to heal. If radiation is done too soon after an operation, then the wound may not properly heal and actually the wound can open up. So radiation, if it's done, is something that's done usually with a couple of weeks or so after an operation like that. Now, in patients with certain primary malignant brain tumors, if they're being followed up and there are recurrence of the tumor, then occasionally we will redo an operation to remove that additional tumor to remove some of the pressure effect. In those cases, there is a chemotherapeutic agent called gliadel wafers, which are little wafers that are put in the area where the tumor was resected that contain a chemotherapeutic agent called BCNU, which can actually help and kill some of the residual cells from the tumor. So occasionally in recurrent, primarily glioblastoma multiformes, these types of tumors can be resected on more than one occasion, and the gliadel wafers can be put in as an adjunct treatment to the treatment of such brain tumors. Now, I hope that this has been an informative video for you. This is not meant to answer all of your questions, and this is meant to just give you an introduction into what we do and why. Any additional questions that you may have, please feel free to speak directly with your surgeon, ask any additional questions, any concerns you might have, and we would be happy to oblige in that manner. No question is too silly, so don't feel that you can't ask us anything, because we're very open to giving whatever information we have, and we'll do our best at answering all of your questions. In any case, we pray and hope that everything goes well, and we'll do everything we can in taking care of you. Thank you.